You can do this in much less than 10 minutes. In fact, I was trying to narrate through it. I'm going to do that myself today as we go through it, but obviously that slowed us down a little bit. So this is something that I commonly will do in clinic that doesn't take more than 4 or 5 minutes once you get used to doing it. So you'll notice I've got him starting standing here in order to assess gait, in order to assess range of motion and some various things. I like to try to minimize positional changes. That way I'm not having them get up and sit back down and then lie down and then get back up. So I'll always start with them standing, do everything I need to do there, move to them sitting, do everything I need to do there, and then from the sitting position, go ahead and lie them down. So here, I start with just assessing. Typically, I'll have them kind of walk down the hall just to assess their gait. Then here within the room, I'll have them walk across the room doing toe walking. Really, they're looking for, in all of these, like I mentioned before, looking at balance, looking for any balance issues. Excuse me. And then in that heel walking, looking at dorsiflexion strength. It's a good functional test for dorsiflexion strength, as well as in toe walking, looking for plantar flexion strength. And then here, once done with that, move on just to assessing them from the posterior. We'll look for any shoulder asymmetries. Also, palpate out their iliac crests. Look for any pelvic obliquity, potential leg length discrepancies there. Also, get a good look at the spine. Does it look pretty straight? Does it look abnormally curved? I'll also there very easily look for any scapular asymmetries. Does it look like they have a wing scapula? Or if I want to look for any scapular dyskinesis, I can put them through a shoulder range of motion. Do a quick Adams forward bend test. Can look for any rib prominence. This guy does not have any. He's got a pretty good straight spine. Look for any lumbar fullness. Really looking for any asymmetry. And then also, while he's there, I can assess his range of motion. Important, I want him to keep his knees straight and hyperextended. I don't want him to flex them. If he starts to flex them, he's gone too far. I want him to go down until he can't with his knees extended. I will describe that clinically as where his fingertips are able to touch. Is he able to put his palms on the floor? Can he touch his fingertips to the floor? Does he do his fingertips go to his ankle joint line or more proximally? Can he not get past the knees? That's a severe loss of lumbar range of motion. I'll take him through extension as well, and then with flexion and extension, I'll also ask, hey, does one of those or the other cause more pain? Just again, hinting more clinically at does flexion or extension cause more pain? I've already gone through through rotation, and then side bending, and then there I was checking for the Stork test, looking for any provocation of pain with hyperextension of the back and hip. And so there he's doing the side bending. So now we've gone to sitting. Excuse me. Checking strength. This is where I'll do the majority of my muscle myotomal strength testing. So checking for knee extensor strength. I'll ask him to point his toes and foot and toes to his nose. And usually most kids will understand that. If they don't, then I do it myself and I point my toes to my nose. Checking for dorsiflexion strength. At the same time, I can check for great toe extensor strength. And then likewise, can check for plantar flexion strength, again, in this in the sitting position. No, you don't have to do that again. You already did it with them standing and walking across, but again, if they were having trouble with that, then you can do it with them sitting. I'll then do sensory testing. I'll start with the arms, presumably if they're there for a low back issue and don't have symmetrical stocking and glove sensory complaints. I'll start with the arms and hands. Hey, this feels soft, right? Same on both sides, pretty soft. So I'll start in the upper thigh and leg and go down. I'll try to go in a little bit more of a dermatomal distribution. Go all the way down the lateral aspect of the upper and lower leg, the anterior aspect, the medial, posterior. I'll go down to the dorsal foot, the deep perineal nerve area, which is in that first and second toe web space, and then, the plantar surface of the foot. Here, looking for neurological long track signs, so checking deep tendon reflexes, the patella, the Achilles. In the Achilles, I find it Most helpful to put them in slight dorsiflexion, just to put some tension on that Achilles tendon, and looking for an ankle jerk. And then from there, can do both ankle clonus testing as well as plantar stimulation. I'll take the bottom of the reflex hammer and just swipe. Let them know, hey, I'm going to do a light swipe across the bottom of your foot. Both of those responses are down going. If that big toe fans up, I'll usually check it again just to make sure it wasn't. They're not withdrawing. So often they'll be very ticklish with these, so you got to take them with a little bit of a grain of salt. If they withdraw, I usually just note that as a withdrawal response. And here, checking for ankle clonus, a quick dorsiflexion jerk. You're looking for that a beating clonus of the ankle, and then you describe that as 1 beat, 1 to 2 beats. I had one yesterday that was 5 beats of clonus, or is it sustained, meaning you do it and it's sustained clonus jerk of that foot, indicating more of a central nervous system, an upper motor neuron sign. Here I'm just illustrating the sitting slump test. So you're putting neural tension on that sciatic nerve. You lift the leg, dorsiflex the foot. You can even have him put his chin to his chest, all trying to increase the neural tension. Here with him now supine, I like to check hip strength, hip flexion strength supine rather than sitting, because they can compensate for that a little bit more. So I'll check hip flexion strength. There, I'm just demonstrating how I check an abdominal reflex. And then I'll take them straight into a straight leg raise. Really focusing on, are they getting that radicular shooting pain down the leg, down into the lower leg, into the foot, or provocation of numbness or tingling where they didn't have it before, between that 30 and 70 degree angle of hip flexion. And then often I'll even put a little bit of dorsiflexion on their foot, or if I'm really concerned that they may have a radiculopathy, even ask him again to raise his chin and put his chin to his chest. I'm sure I had something riveting there to say. She can't hear it. I think I'm commenting on the Contra lateral straight leg raise. So for instance, if I was concerned of a left-sided radiculopathy, not on the right, I'd lift the right, and does that provoke radicular symptoms in the left leg? Would be a positive contralateral straight leg raise. Here, also, again, if I'm concerned for underlying hip pathology, I just take them right into hip range of motion. You can see his hip flexor there on the left is just a little bit tight. Ideally, that hip should stay flat. When you flex the contralateral hip. So there I'm taking him into internal range of motion, external range of motion, and then I'll usually assess that at degrees. You can see where I was there is at neutral, so then I describe that as how many degrees from neutral, and then slide right into a Faber test, putting some distraction force on the contralateral iliac crest while putting a distraction force on that knee. Again, does that provoke your pain? If so, is it in the groin? Potentially more related to hip joint pain versus in the posterior aspect, which is a little bit more SI joint pain. This is the Gainsland's test, like I was describing earlier. Have him hang that leg, hyperextend or extend that hip off the table, flex the knee, and then I'll put, again, another distraction force, trying to stress that SI joint of the hip that I'm extending there. Does that provoke pain? And then I'll typically ask them to pull to their chest. Here's the SI distraction test, where I just quite literally put both palms on the aspects of both ASIS and put a distracting force to see if that provokes SI joint pain. Here's that SI compression test that I was describing earlier, where you're, again, finding the iliac crest and put a downward pressure. Does that provoke SI joint pain? Can also palpate the greater trochanter while I'm there, see if they have any over that prominence, and see if they have any trochanteric pain, hinting at maybe bursitis or gluteal tendinitis. Here I can check their hip AB ductor strength if I need to, also doing an Ober test, which I didn't comment on earlier, but that's really a test to look for a motion restriction in the IT band. So when he's lowering his knee there, could he lower his knee behind the other leg? Does it touch the table? If it touches the table, generally tells you they have pretty good motion. If it does not, or there's space between the knee and the table, hence there may be a motion restriction in their IT band. It may be tight. And then here I'm checking the femoral nerve stretch test. So I can forcibly flex the knee with him in prone. Does that reproduce femoral nerve symptoms, radicular symptoms? And then one step further, do I want to take it a step further and extend his hip, further putting a stretch on there?